Last-minute flashcard videos. Last-minute flashcard videos are concise videos that present high-yield clinical case scenarios and prompt responses, addressing clinical concepts pertinent to exam preparation in the days prior to the pediatric board exam, covering more than 2,000 high-yield facts in 11 hours and classified by specialty. This video has a collection of last-minute flashcards from several subspecialties. An infant with isolated pre-auricular skin tags. Renal ultrasound is not indicated if no other congenital anomalies or risk factors. Very important to know that the risk of permanent hearing impairment in a newborn with isolated pre-auricular skin tags or PITs is 5-fold higher compared to the general population. So if this baby passed the neonatal hearing screening, this should be sufficient. Adolescent wrestler with blue swelling and redness in the right ear pinna occurred during a school match. Auricular hematoma. This will require urgent aspiration of the hematoma and pressure dressing. A 9-month-old with a temperature of 39 Celsius, 102.2 Fahrenheit, with fussiness and poor feeding. On exam, bilateral bulging tympanic membrane. What is the best treatment option? Antibiotic treatment because of the high fever and symptoms, for example, amoxicillin 90 mg per kilo per day. Preterm infant plus respiratory distress. Chest X-ray is positive for ground glass appearance and air bronchogram is surfactant deficiency disease or respiratory distress syndrome. Newborn respiratory distress, absent breath sounds on the left side, scaphoid abdomen, chest X-ray shows intestinal structure in the left side of the chest. This is congenital diaphragmatic hernia. Pneumatosis intestinalis, as you see here, air in the intestinal wall, is pathognomonic to necrotizing enterocolitis. Gas in portal vein is a poor prognostic factor. Formula feeding is a risk factor and a well-known cause in premature infants. Renal vein thrombosis in neonates presents with sudden onset of hematuria, flank mass in one or both sides. Risk factors: sepsis, shock, dehydration, maternal diabetes mellitus, or hyperthrombosis or hypercoagulable states. Brachial plexus injuries. Risk factors: large baby or large for gestational age, breech presentation, or difficult vaginal deliveries in general. The most common type is Erb's palsy. The injury at the level of C5 and C6, the arm will be adducted close to the body, internally rotated, and the hand will be in waiter tip position. Other rare type is clump palsy, and the injury at level of C8 and T1, the hand will be a claw hand position. One important sign of brachial plexus injuries in general is elevated hemidiaphragm in X-ray or phrenic nerve injury. Lumbic palsy can be associated with Horner syndrome, which is ptosis, anhidrosis, and meiosis or unequal pupils. What are atopic disorders? Again, atopic disorders are atopic dermatitis, asthma, allergic rhinitis, food allergies. What are the indications of allergy testing? Significant cases of allergies, for example, asthma, anaphylaxis, food or drug allergies, difficult to treat allergies, or requirement for specific treatment. A 4-month-old with severe eczema, peanut specific IgE screening is negative, less than 0.35. What is the next best step? Introduce peanuts between age 4 and 6 months. A 4-month-old with severe eczema, peanut-specific IgE screening is positive, more than 0.35. What is the next best step? Referral to an allergist for peanut skin prick test before 6 months of age. A 16-year-old male with a new watch notices an erythematous area located on the wrist where the watch was worn. No other lesions in the body. This is a case of contact dermatitis, type 4 allergy, delayed hypersensitivity reaction. You will see the erythema or the reaction is taking the shape of the object. For example, if it's a watch, will be in the wrist. If it's a belt, will be in the abdomen. If it's a earring, will be in the ear. The best treatment, avoid offending agents. A child was started on medicine for seizure 4 weeks ago and started having urticarial maculopapular eruption, vesicles, and bulli on extremities. Is having fever, cough, lymphadenopathy, eosinophilia, elevated liver enzymes, proteinuria, and hematuria. What is the most likely diagnosis? Drug reaction with eosinophilia and systemic symptoms syndrome or DRESS syndrome. The key words here, new medication, for example, seizure medicine. And few weeks later, the child will start to have urticaria, facial edema, lymphadenopathy, eosinophilia on laboratory, very important, and internal organs involvement, for example, liver and kidney. So again, drug reaction with eosinophilia and systemic symptom syndrome or DRESS syndrome. What is the most common specific autoimmune disease associated with chronic urticaria? Autoimmune thyroid disease, for example, Hashimoto thyroiditis, Graves' disease. So it is a good idea when you are investigating any child with chronic urticaria to include TSH, free T4, and thyroid antibodies. Sudden onset of lip swelling, abdominal pain, swelling of both feet, non-pruritic erythematous skin rash, and one family member has the same condition. Hereditary angioedema. Usually the swelling comes all of a sudden, like swollen lips, eyes, swelling of both feet or hands, and the rash is non-pruritic and positive family history. The cause of hereditary angioedema, low levels or decreased function of plasma protein C1 inhibitor, and it is autosomal dominant. Best screening test, C4 level, is the most reliable and cost-effective screening test for hereditary angioedema. Again, C4 level is the best screening test. A 6-year-old male with yellow tan macules located on the upper extremities. Parents notice localized erythema following scratching of the lesions and after taking a hot shower. Mastocytosis. The erythema appears after scratching the skin. This is called the rear sign. Is urticaria after stroking lesions. Persistent pulmonary hypertension. This condition must be differentiated from transposition of great arteries. Differential cyanosis, here the oxygen saturation is lower in the lower extremities than the right arm, the opposite in case of transposition of great arteries. This condition can be associated with meconium aspiration syndrome. During the first 48 hours of life, a newborn rapidly or suddenly develops cyanosis, tachypnea, respiratory distress, pallor, lethargy, metabolic acidosis, oliguria, weak pulses in all extremities, soft first heart sound and loud second heart sound, ejection systolic murmur along the left sternal border, and hepatomegaly. What is the most likely cause? This is a classic presentation of hypoplastic left heart. Once the ducts start to close, this infant will develop sudden deterioration and development of cardiogenic shock. Look for weak pulses in all extremities, loud second heart sound. These infants may have murmur or may not have any murmur. Very important to know. A 2-week-old boy develops congestive heart failure, severe metabolic acidosis, poor perfusion of the lower extremities. What is the most likely cause? This is a classic presentation of coarctation of aorta. Once the ducts start to close, this infant in severe case of coarctation of aorta will develop cardiogenic shock. When do we need to give prostaglandin? We have to keep this clear in our mind. If you have a newborn presenting with severe cyanosis, increased pulmonary vascular markings, narrow mediastinum, poor response to 100% oxygen, this is a transposition of great arteries or vessels. The next step is to give prostaglandin. If you have a newborn with signs of right-sided obstruction, presenting with severe cyanosis and decreased pulmonary vascular markings or dark lung, for example, severe form of tetralogy Fallot, critical pulmonary valve stenosis, pulmonary atresia with intact ventricular septum, Ebstein anomaly. The next step is to give prostaglandin. Also, if you have a newborn presenting with signs of left-sided heart obstruction, presenting with cardiogenic shock and metabolic acidosis, for example, hypoplastic left heart syndrome, coarctation of aorta, interrupted aortic arch. The next step is to give prostaglandin to keep the ductus open. In this slide, we'll differentiate between three important causes of congenital cyanotic heart defects. The first one, an infant presenting with cyanosis, boat-shaped heart, and decreased pulmonary vascular markings. Second one is a newborn presenting with severe cyanosis, poor response to oxygen, narrow mediastinum, and egg on a string shaped heart, and increased pulmonary vascular markings. Third one, a newborn presenting with cyanosis, large right atrium, and decreased pulmonary vascular markings. This is a classic presentation of tetralogy fellow, transposition of great arteries, and Ebstein anomaly. Newborn presenting with severe respiratory distress, hypoxemia, cyanosis, diagnosed initially as respiratory distress syndrome because of ground glass appearance of the lung, and in chest x-ray there is a large supracardiac shadow giving the heart a 8-figure shape or snowman appearance, and increased pulmonary vascular markings or ground glass appearance of the lung. What is the most likely cause of this condition? Total anomalies of pulmonary venous return. Suspect this condition in a newborn with diagnosis of respiratory distress syndrome not responding to oxygen or lung surfactant. Child presents to the emergency department with rapid breathing, low blood pressure, normal oxygen saturation. On exam, you find tachypnea, tachycardia, clear lungs, but muffled heart sounds, and wide pulse pressure. What is the most likely diagnosis? Cardiac tamponade. The most important signs of cardiac tamponade are respiratory distress, for example, tachypnea, tachycardia, clear lungs, and muffled heart sounds, plus wide pulse pressure. A 12-year-old girl was transferred to the emergency department after a car accident. She is complaining of chest pain on the left side and difficulty breathing. On exam, vital signs are normal, however, she has fast and shallow breathing. A segment of the left chest moves inward upon inspiration and outward upon expiration. What is the most likely diagnosis? Flail chest. The key words for flail chest: car accident or trauma, chest pain and difficulty breathing. And on exam, the segment or the affected segment will move inward upon inspiration and outward upon expiration. And the best next step is pain control, pulmonary toilet, ensure adequate ventilation and oxygenation. A 6-year-old boy wakes up in the middle of the night scared. He remembers a giant monster was trying to eat him. Nightmares. Reassure the child. Television viewing should be avoided about 2 hours prior to bedtime. Very important to know that nightmares, the child will remember the dream. And nightmares occurs during REM sleep or rapid eye movement sleep. A hint to remember: REM sleep is a nightmare and the child will remember. RR. REM sleep is a nightmare and the child will remember. The parents of a 4-year-old girl have noted episodes of screaming, intense fear, with difficulty of arousal that occur several times per week. She doesn't remember the episodes. Night terrors. Very important to lead the child back to sleep and avoid awakening the child or talking to the child. Reassure the parents. Preemptive awakening before the episodes and safety precautions if the episodes are frequent. Remember, night terrors occur during stage 4 non-rapid eye movement sleep and during the first third of the night. A hint to remember: night terror, non-rapid eye movement sleep, and not able to remember. An adolescent was on fluoxetine for depression for the last 15 months and stopped the medicine suddenly. She started complaining of dizziness, fatigue, lethargy, myalgias, chills, headaches, nausea, diarrhea, insomnia, vertigo, paresthesias, anxiety, irritability, and agitation. This is a withdrawal syndrome. That's why when we stop the fluoxetine, we have to stop it gradually over 3 to 4 weeks. Stopping selective serotonin reuptake inhibitor suddenly can cause a withdrawal syndrome. Should be tapered over 4 weeks. A 4-year-old boy with rash around the mouth for 2 weeks is not going away. The mother is been applying topical hydrocortisone, and the rash keep getting worse. What is the most likely diagnosis of this rash around the mouth? Periorificial dermatitis. The common trigger of this type of rash around the mouth using inhaled steroids or topical steroids around the mouth. What is the management of periorificial dermatitis? Topical antibiotics such as metronidazole or clindamycin. For severe cases, oral tetracyclines or erythromycin. Improvement is slow. Very important to teach the parents. It may take 6 to 8 weeks to clear. 15-year-old boy with a sudden onset of rash looks like water droplets covered with fine psoriasis scales. He had a streptococcal throat infection 2 weeks ago. What is the diagnosis? Guttate psoriasis. Gutta means drops, commonly triggered by a streptococcal infection during acute infection or shortly after. Child with peanut allergy presents with diffuse hives, flushed skin, and vomiting after ingestion of peanuts. What is the definitive treatment for the most likely underlying diagnosis? Immediately give intramuscular epinephrine for acute anaphylaxis. The dose is 0.15 milligrams for less than 30 kilos and 0.3 milligrams for more than 30 kilos. Child presents to the emergency department with a dog bite. What is the next best step? Wound cleaning with adequate pressure irrigation and the initiation of antibiotic treatment. Amoxicillin clavulanic acid cover both aerobes and anaerobes, especially Pasteurella. Clindamycin plus trimethoprim sulfamethoxazole or Bactrim if allergic to penicillin. Combination of clindamycin and Bactrim if allergic to penicillin. A 10-year-old boy was bitten by a rattlesnake in his right arm in the backyard. Parents called you asking about first aid advice. Move the child to a safe place, keep him warm, calm, and as still as possible. Remove all constrictive clothing and jewelry and gently clean the wound with soap and water. Keep the arm at level of his heart. Mark the edge of pain and swelling on the skin and call the emergency. Call 911 for immediate transport to emergency facility and the local poison control center if possible. For a snake bite, what do you tell parents not to do? Do not place a tourniquet. Do not suction the wound. Do not incise the wound. Do not apply ice. Do not allow the child to move the extremity. Toddler ingests a small amount of windshield wiper fluid about 30 minutes before the presentation. Is asymptomatic. Caretaker calls the primary care office for advice. What is the next best step? Immediate referral to the emergency department for further laboratory testing. This is toxic alcohol ingestion, which is methanol found in windshield wiper fluid. This can cause visual disturbance, abdominal pain, and high anion gap metabolic acidosis, weight loss, abdominal pain, nausea, effortless postprandial regurgitation after at least one meal daily for 1 month. Regurgitated food occasionally re-swallowed, re-chewed, or spit out. Rumination syndrome is more common in children with intellectual disability or developmental delays, and the best management is diaphragmatic breathing, cognitive behavioral therapy, biofeedback, and relaxation training. Child with no known health problem woke up suddenly vomiting blood. The child is stable and acting normal. What is the most likely cause? Epistaxis, the most common source of blood in cases of vomiting in healthy children, is nose bleeding, and the blood will escape to the stomach at night while asleep and will cause nausea, then vomiting. So in any case like that, it's very important to examine the nose. Infant suddenly develops bilious vomiting, abdominal distension, tenderness, and fussiness. What is the diagnostic test of choice? Bilious vomiting, especially if it's recurrent, is a serious symptom suggesting bowel obstruction. So the best next step is to order upper GI series with follow-through immediately. So this is a case of volvulus. If you see here, this is the upper GI series with water contrast, water-soluble contrast, and showing corkscrew appearance, corkscrew appearance of the duodenum not crossing the midline. So this is a case of bowel malrotation. Runs well, makes 4 block tower, points to 3 body parts, uses 10 to 25 words. 18 months. Kicks ball without demonstration, throws a ball overhead, builds a tower of 6 blocks, jumps with 2 feet, 2-word sentences, 50% intelligible speech. 2 years. Catch-up immunization is a high yield and frequently tested by American Board of Pediatrics and is very important clinically as well. I will give few examples, but for more details you can go to the website of CDC for most updated information on catch-up immunization schedule. Unvaccinated 9-month-old boys coming to catch up on immunizations. What vaccines can be given today? Give hepatitis B, DTaP, IPV, Hep or Haemophilus influenza vaccine, and pneumococcal vaccine. No rota is required at this age. When he can come back for the next set of shots, and what vaccines can be given. To come back in 4 weeks and to receive hepatitis B, DTaP, IPV, Hep, and PCV, which is same set of shots as the first time. Both sexes are equally affected. Both sexes transmit to offspring. No skipped generation. Every child has a parent with disorder except new or spontaneous mutation. What is the most likely mode of inheritance? Autosomal dominant. You see here the father is affected, and in the offspring you will see a boy is affected, and on the other hand a girl also is affected. So both sexes are equally affected. No skipped generation. In the subsequent generation you will see here this is a father and a boy and girl are affected, and this is a mother, boy and girl are affected. So both sexes are equally affected. Both sexes are equally affected. Both sexes can transmit the mutated gene, and the risk to have affected child is 25%. The disorder may be seen in one or more siblings, and not all generations are affected. What is the most likely mode of inheritance? Autosomal recessive, and the highest risk is with consanguineous marriage, increasing or has the highest risk to have 2 mutated genes together. What are the best initial studies in cases of suspected iron deficiency anemia? Best initial studies: complete blood count or CBC, reticulocyte count, soluble transferrin receptor level, and ferritin level. Ferritin is the storage form of iron. What are the expected lab results in cases of iron deficiency anemia? All of the following will be low. Low hemoglobin, low mean corpuscular volume or MCV, low total iron, low reticulocyte count because the bone marrow is not making enough red blood cells because of lack of iron, and low iron storage, low ferritin level. All of the following will be high. High soluble transferrin receptor level. The soluble transferrin receptor is a protein or amount of protein fragment called soluble transferrin receptor present in blood, which serves as a marker for iron deficiency. When is elevated means iron deficiency. Red cell distribution width or RDW will be elevated or high. Total iron binding capacity or TIBC will be elevated, and Minzer index will be more than 13. What is Minzer index? Is the MCV, which is the mean corpuscular volume, divided by the total red blood cells in million. If it's more than 13, this means iron deficiency anemia. What are the best initial studies in cases of suspected iron deficiency anemia? Best initial studies: complete blood count or CBC, reticulocyte count, soluble transferrin receptor level, and ferritin level. Ferritin is the storage form of iron. What are the expected lab results in cases of iron deficiency anemia? All of the following will be low. Low hemoglobin, low mean corpuscular volume or MCV, low total iron, low reticulocyte count because the bone marrow is not making enough red blood cells because of lack of iron, and low iron storage, low ferritin level. All of the following will be high. High soluble transferrin receptor level. The soluble transferrin receptor is a protein or amount of protein fragment called soluble transferrin receptor present in blood, which serves as a marker for iron deficiency. When is elevated means iron deficiency. Red cell distribution width or RDW will be elevated or high. Total iron binding capacity or TIBC will be elevated, and Minzer index will be more than 13. What is Minzer index? Is the MCV, which is the mean corpuscular volume, divided by the total red blood cells in million. If it's more than 13, this means iron deficiency anemia. Hematology and oncology last-minute flashcards. What are the best initial studies in cases of suspected iron deficiency anemia? Best initial studies: complete blood count or CBC, reticulocyte count, soluble transferrin receptor level, and the ferritin level. Ferritin is the storage form of iron. What are the expected lab results in cases of iron deficiency anemia? All of the following will be low. Low hemoglobin, low mean corpuscular volume or MCV, low total iron, low reticulocyte count because the bone marrow is not making enough red blood cells because of lack of iron, and low iron storage, low ferritin level. All of the following will be high. High soluble transferrin receptor level. The soluble transferrin receptor is a protein or amount of protein fragment called soluble transferrin receptor present in blood, which serves as a marker for iron deficiency. When is elevated means iron deficiency. Red cell distribution width or RDW will be elevated or high. Total iron binding capacity or TIBC will be elevated, and Minzer index will be more than 13. What is Minzer index? Is the MCV, which is the mean corpuscular volume, divided by the total red blood cells in million. If it's more than 13, this means iron deficiency anemia. Hemolytic anemia. If you have a patient with jaundice, splenomegaly, gallstones, mild to moderate anemia, increased retic count, increased mean corpuscular hemoglobin concentration, MCHC, and small red blood cells with loss of central pallor. As you see here in the peripheral smear, the red blood cells here is smaller than the size of the nucleus in lymphocytes and with loss of central pallor. It is hyperchromatic plus hyperbilirubinemia. What is the most likely diagnosis? Hereditary spherocytosis. Confirm the diagnosis with osmotic fragility test. Another case scenario: African American or Mediterranean, presenting with dark urine, sudden onset of pallor and anemia. Recently was started on medicine, for example Bactrim for UTI. Peripheral smear is positive for Heinz bodies. High retic count, hyperbilirubinemia, splenomegaly, decreased haptoglobin. And you suspected G6PD from the clinical presentation, and you ordered G6PD activity during the active episode of hemolysis, and it came back negative. What is the most likely diagnosis? G6PD deficiency is the most likely diagnosis, even with negative enzyme activity. Why? Because this test was done in the wrong time during active hemolysis. During active hemolysis, most of all the red blood cells with deficiency of G6PD are already destroyed. So when you do this test during this time, it will give you false negative results. Why? Because the body will compensate to produce more immature red blood cells, more reticulocyte, and this is they have increased G6PD enzyme. So this will give you false negative results. So the best time to do the testing for G6PD during remission, not during active hemolysis. If you have a child presenting with fever, gingival swelling and bleeding, blisters on the lips and gingiva, drooling because of pain, and looks dehydrated, what is the most likely cause? herpetic gingivostomatitis, high fever, poor feeding, severe throat pain in older children, drooling, very small vesicles, and ulcers in both tonsils. What is the most likely cause? This is an enterovirus infection causing stomatitis because of ulcers in the back of the throat. You may see herpa angina in the choices, you may not. So be familiar with this name. This is enterovirus, subtypes Coxsackie virus. So be familiar with all these names: herpa angina, Coxsackie virus infection, or enterovirus stomatitis. Can be with or without rash. Fever, vesicles, and ulcers on buccal mucosa and hard palate, tongue. Erythematous maculopapular rash all over the body, petechial rash on the palms and soles. What is the most likely diagnosis? This is hand, foot, mouth disease. Be familiar with enterovirus infection with exanthem. You may not see hand, foot, mouth disease in the choices. This is an enteroviral infection. This is a classic presentation of nephrotic syndrome due to minimally changed disease. Nephrotic syndrome not responding to treatment and progressing to chronic kidney disease is well known as focal segmental glomerulosclerosis. Remember all the key words for minimally changed disease: the age less than 6, and edema, normal blood pressure, 4 plus protein or proteinuria more than trace, no hematuria, hyperlipidemia, hypoalbuminemia, normal C3 and C4, and responsive to steroid therapy. A 5-year-old has blood in urine. Urine is positive for hematuria and red blood cell casts. Renal function is normal. No hypertension. Positive family history of hematuria with every generation affected. Familial thin basement membrane nephropathy. It is autosomal dominant. Remember the key words: hematuria with positive family history. No other symptoms. Self-limited epilepsy with centrotemporal spikes. The key words here: seizures soon after sleep onset or just before awakening, and mostly at night. Associated with paresthesia of the mouth, facial twitching, drooling, and normal neurocognitive development. This type of seizure, self-limited epilepsy with centrotemporal spikes from the name, is benign, and because it's typically nocturnal and infrequent, there is no absolute indication to treat. If you decide to treat, the treatment of choice is carbamazepine. This is a 16-year-old girl presents with myoclonic jerky seizures involving upper extremities upon awakening, generalized tonic-clonic all over the body, being sensitive to sleep deprivation, stress, and alcohol, and EEG is 4 to 6 Hz, spike and polyspike wave, difficulty holding objects and looking clumsy in the morning. Juvenile myoclonic epilepsy. From the name, juvenile, common during adolescence, and myoclonic jerky seizures, generalized tonic-clonic, and is common upon awakening in the morning, and sensitive to sleep deprivation. The EEG is 4 to 6 Hz, and difficulty holding objects and looking clumsy in the morning. Epidural hemorrhage appears on CT scan as convex lens-shaped hyperdensity. Subdural hemorrhage appears on CT scan as crescent-shaped hyperdensity. 8-year-old boy presents with limping and pain in the left hip and knee. Plain radiograph shows ossified and collapsed femoral epiphysis. You see here, the femoral epiphysis is collapsed. Here looks normal. What is the most likely diagnosis? Perthes disease or leg calf Perthes disease. The key words here: limping and pain in the affected hip. The pain can be referred to the knee, very important to know, and collapsed femoral epiphysis. If you have these two keywords, limping or pain or both, and collapsed femoral epiphysis, this is a case of Perthes disease. An adolescent with obesity presents with limping and pain in the right hip and knee. Plain radiograph shows displacement of the femoral epiphysis. As you see here, the left femoral epiphysis is displaced. Here looks normal. Slipped capital femoral epiphysis. The key words here: limping and pain or both in the affected hip, and the pain may be referred to the knee.
And on X-ray, you will see displacement of the femoral epiphysis as you see here on the right side.
Visit lastminutepediatric.com to view most recent flashcard videos and courses covering all pediatrics.